Hello and welcome to our cerebral palsy training workshop. So this one is about designing and implementing a rehab program for an individual with cerebral palsy. My experience with cerebral palsy has been predominantly those who are adults, so this is more around individuals who are adults. Please still feel free to read if you do work with children. The focus is just a little bit different. So to give you an idea of what we're going to talk about today, the learning outcomes include understanding the basics of cerebral palsy, the characteristics in a rehab environment for someone with cerebral palsy, the difference between spasticity and flaccidity, understanding muscle tone, strategies for home-based exercises, as well as a few strategies in there for school and community-based exercises. The course content today is looking at those areas. So we look at the definition, characteristics and etiology of CP. We look at behavioural difficulties that sometimes impact a rehab program. We also look at the communication difficulties. Some people with cerebral palsy have difficulty with particularly expressive language, so I give you a few tips on that. And we look at some financial difficulties, the role of family members, support workers and other allied health that come together when we provide a rehab program, and also looking at how we prescribe to people in the healthy population and how that's different when we provide a rehab program for someone with a disability. So feel free, if you have any questions, please email me, or we have an online forum and I'm here to help you with whatever you need. As I said, my specialty has mainly been rehab programs for adults with CP. So I look at helping with their day-to-day functioning. Some of my clients also have general fitness goals, such as walking in a marathon, getting higher up in their swimming career. So it's not just rehab, it's also a lot of exercise fitness goals as well. So please enjoy the session and I look forward to hearing from you. So here we go. Cerebral palsy introduction. What is cerebral palsy? Cerebral refers to brain and palsy refers to a disorder of movement or posture. Cerebral palsy, I will term it as CP throughout the session, is a static neurological condition resulting from brain injury that occurs before cerebral development is complete. It's considered static, but the physical symptoms can progress and change over the lifespan. This could be due to a range of physical, environmental, and lifestyle factors. Symptoms may vary from total inability to control body movements to only slight impairment. So it works on a spectrum from mild to moderate to severe, and the symptoms generally I see the symptoms are generally in the extremities. You'll notice it most with a clasped hand or difficulties with club foot and movement of the ankles. And then I find that as the severity goes up, it starts to affect more of the larger muscle groups. As you may already know, there are a few different types of CP. CP is classified according to the body parts that it's affected. So hemiplegia CP is one half of the body is affected. So that picture there is in picture A, the one on the left. Diplegia is the legs are more affected than the arms. So that's the child in column B. And quadriplegia CP is the whole body is affected. So that's in C. So that will be upper body and lower body affected by CP. I have found it quite challenging finding up-to-date pictures for CP, so please do bear with me with the images that you're seeing. I hunted high and low for these to try and show you what it may look like for the different types. So again, we're looking at hemiplegic CP on the left-hand side, where it's down particularly one side of the body. In this picture, it's down the right-hand side. It can be down the left-hand side. Diplegic, or some people call it paraplegic, is both legs more impacted than the upper body. The upper body can still have very minor signs or even neurotypical signs, but the contractures or the challenges in the muscles will be in the ankles and feet predominantly. And then on the right hand side you've got your quadriplegic CP, so that is upper body and lower body. So, and it can also include the head, voice, mouth, So that's we're looking at a little bit more down the severe continuum of CP. So I tend to work with clients from all types of CP. When I work with people who have upper body and lower body, obviously my goals and my strategies are different to those who are hemiplegic or diplegic. But not to say that we can't rehabilitate and work on muscles for any of these types. All of these types can benefit from exercise. It's just helpful for us to know the type of CP that we're working with, so our strategies can be appropriate for the needs of each client. CP can also be classified in the type of movement disorder that it comes with. So some people will have, as we were saying, hemiplegic, diplegic or quadriplegic CP, so looking at the areas of the body that it affects. And then we also can classify it in what the motor disorder is. So we have spastic CP, so that means the muscles are high in tone and we have spasticity in the muscles. We also have athetoid and dystonia CP, so that could be where the tone of the muscles is affected by the palsy component of cerebral palsy. Ataxic CP can be as we go to move, the messages aren't accurate, so we might have quite rigid or quite unusual types of movement as we try to move. And then mixed CP can be that we have a combination of these three types, so spastic, I call it athetoid, and ataxic CP. And mixed CP, we sometimes will have something, a type of motor disorder, for example, happening in the upper body with a different type of motor disorder happening in the lower body. So it's quite complex, and I really want you to take out of this session that every individual is different. So I make sure I read the medical history of each individual. I chat to family and of course the individual themselves of the challenges that they're having, because one exercise program for one person with CP is not going to match everyone. So we really need to have a holistic approach and get as much information and about the individual as we can. Throughout my training packages, I like to just put questions out there to get you thinking. So, athetoid CP is the rarest form of CP. Is this true or false? Go through our material, keep it in mind, and I use this to make sure you're listening. Let's start with the first type of CP, so it's spastic CP. This is the most common form. The muscles are very tense and contracted and they're resistive to movement. The symptoms of the spasticity is worse when they're upset, when they're trying to exert a lot of effort, when they've moved too quickly or vigorously, or particularly you'll see it if the body experiences a sudden loud noise, the movements will jolt and the spasticity will increase. I also find that some of my clients, when they're really finding excitement and we're laughing, you'll see that the spasticity will be more obvious. What's happening in this type of movement disorder is there's an increased stretch reflex, so it responds to rapid passive stretching with vigorous muscle contractions. So you'll see that the pictures here, the joints will be quite contracted, not just at the ankles and the hands, but you can even see behind the knees, the hip joints, even all the way down to the fine movement of the jaw. All these contractures can impact not only picking up objects, walking, standing, it can also impact someone's ability to chew, swallow, speak, keep their body upright. So the movements that they experience can involve tremors. The movements can also be quite jerky, weak, and they think that they're going to make a particular movement, and then the uncertainty of that movement can come and the outcome of the movement is different to what they were planning for. So a lot of the times when we work with people like this, it's dealing with their frustration of the mind wants to do something and the body isn't listening. So we work a lot with relaxation, a lot with changing the mindset so they can, we don't want to give up, we want to keep trying, but a lot of it, I can't even imagine how frustrating it could be for people with CP. So being mindful of that. Basically, the muscular, we call it hypertonicity, so the tone of the muscles is way too high. This is during voluntary movements, so when we're trying to shift our body from one position to another, when we're trying to pick up an object, the muscle tone is just too tight, and that's where the weakness and the jerkiness comes from. In these pictures, you can see that there would be unique gait patterns for someone with spastic CP. So they tend to have difficulty with the typical heel to toe strike as they're walking. We'll also have difficulty getting in and out of a chair cleanly and smoothly because these movements are quite weak and jerky. So there's a lot to think about in CP. I'd really love you to know that it's not just a clear cut, this is what we do. We have to look at all the different types of CP and how movement is impacted by this condition. The next slide that I'd like to talk about is athetoid or dystonia CP. This is the second most common type of CP. It's classified by involuntary or uncontrolled movements of the body parts. So where before the spastic CP was particularly with movements that you wanted to carry out, so the muscles will contract differently when we go to move or pick up an object or change our body position. This type of CP is the movements happen when we're just sitting without trying to move our body at all. Usually you'll see this in rest when they're just sitting still. So there's this jerky, slow, wriggling type writhing movement of the legs, arms, hands or face. What you'll sometimes be classified with is they have hemiplegic athetoid CP. That could mean hemiplegic means that it's down one side, athetoid means that it's happening when it's involuntary, when the body isn't trying to plan a movement. And it's these writhing movements of a particular part of the body that you can see in these people in these individuals who have this type of CP. So the involuntary movements that you'll see happen more so when they're stressed or excited, and you can see the body starts to relax when they're feeling calm, or particularly it's absent when they're sleeping. So we try and work on teaching the body to relax, and we try and teach the body, particularly we manage things like anxiety, because if we can manage the anxiety, we can reduce the stress in the muscles and they can start to experience less of that involuntary movement. Typically, you'll also find that there's still presence of infantile reflexes and there's difficulty controlling these muscle contractions. Often people with athetoid CP will, again, we talk about frustration because they become frustrated when they're trying to relax. You know, you can imagine just sitting there trying to relax and the body goes through these movements that can be quite uncomfortable. So we're trying to work on controlling the muscle contractions, slowing down those involuntary muscle contractions. A lot of it takes not just rehabilitation that we're looking at, we're also looking at the sensory system, we're looking at the postural system, so there's a lot involved when we help someone with athetoid CP. In athetoid CP, they have a fluctuating muscle tone. So as spastic CP, you're seeing a lot of hypertonia. In athetoid CP, you can see both. You can see hypertonia, so the muscle tone is too high, and you can also see hypotonia, or also known as flaccidity, where there's decreased muscle tone. So you'll see in these pictures of the baby, when we go to lift the baby up, that's a sign of hypotonia, where they are quite floppy and they don't have the tone that they need. We need tone to be at a neutral, optimal level. If it's too low, then we don't get the effective movement that we want, and if it's too high, then we don't get the effective movement that we want. So trying to get that neutral muscle tone is really important. The least common type of CP is called ataxic CP. It involves hypotonic or flaccid muscle tone. So some people would call this floppy. Some people would look like nearly like a ragdoll cat, where they go to move and the body just sort of collapses under gravity and under weight. Hypotonic, whenever you see the HYPO part, it usually means low or under, where hyper, where you see HYPER, it means too high or above what we would need for accurate muscle tone. So it predominantly impairs balance and coordination because we go to move or we go to pick up something, and as our muscles hit gravity, gravity tends to take over the muscle tone. So you might see they'll look unsteady or shaky. There might be some tremors there because the muscles are trying to keep up against gravity, but they just can't have that strength. And you'll see it's typically obvious when they're trying to do ADLs, or what we call activities of daily living. So it might be brushing our teeth, trying to hold up all of our muscles to be able to hold that toothbrush in our mouth. It might be going from a bowl of yogurt with a spoon from the bowl of the yogurt to our mouth. Our muscles might start to get quite floppy. We might have a few mistakes in movement. There's also, if you can imagine, when we're standing still like the lady in the picture, we'll have an increased postural sway. So we'll move slightly from side to side. And again, it's just those muscles having trouble keeping the body upright. That girl there has what we call a wide base of support. So the body makes adaptations to the way we stand and the way we walk to keep us more balanced. So we call that a wide-based gait. And it basically, the arms out to the side is the body's always trying to catch itself before a fall. And this can be quite common in the ataxic CP. I've seen a few people with this type of CP where it can look similar to other neurological conditions, particularly with the tremors that they have. So some people might confuse an elderly person with ataxic CP with Parkinson's if they don't understand the difference between tremors. It's just trying to support them through their activities of daily life. I found that sometimes strengthening up the muscles can help, because it can help the muscle tone to increase, and it can help the muscles to withstand that pressure of gravity. But we'll talk to you more about that later on. There's also moments, so some individuals who have mixed CP, so they might have spastic CP in some areas and ataxic CP in other muscle groups. So it's really important, as I keep saying throughout the session, to get a full history, to talk to the individual if you can, or if the individual finds it difficult to share their medical history with you, talk to their families, their carers, and anyone else who has worked with them, so we can make sure that the goals of our exercise program match the exact goals of their muscular and neurological system. Here I talk about the causes of CP, and I've taken some of this information from a few references. You'll see the reference slides all the way down the bottom of the session, so feel free to read through those if you need. So this is from Redhoff and Collins in 2003. They're saying that there's a few different causes for CP. So sometimes it's from perinatal causes, so problems during the labour and delivery of a baby. It could be due to the obstetric emergencies of an obstructed labour, hemorrhaging, or cord prolapse that causes hypoxia, so decreased oxygen to the brain. It could also be neonatal problems, so the baby may be born at less than 32 weeks gestation. The baby may be born at less than 5 pounds 8 ounces. They've done studies on intrauterine growth, intracranial hemorrhaging. So there's a list of all these different things that could happen for neonatal problems for the baby. I want to really make sure that people are aware that just because you have these risk factors, or just because this has happened, doesn't necessarily mean CP. It's just the research that they've done has found that these may be happening for a baby who has developed CP. Redhoff and Collins reported that because brain development continues during the first 2 years of life, CP can result from brain injury not just occurring during prenatal or neonatal, but also postnatal periods of development. So we're looking at firstly prenatal, what's happening before the baby is born. It could be that they have a congenital brain malformation. There may be issues with the vascular system in the womb. There may be issues with maternal infection during the first and second trimesters of pregnancy, or the least common factors may be a metabolic concern or any toxins or rare genetic syndromes. The other components are in the areas of neonatal, what has happened to the baby's development, and then postnatal, what has happened during and after birth. And then with the postnatal causes, we may be looking at an infection such as bacterial meningitis, viral encephalitis. There may have been an injury such as a vehicle accident, a cerebrovascular accident, so say a TIA or a stroke, or they may have been damaged following surgery. So again, it's so complex in what the possible cause could have been, and we really need to know as much information as we can. So again, we know what we're trying to help these people with. French Tooth in 2004 reported that the most common cause of CP is an insufficient amount of oxygen reaching the brain. So again, we're getting a lot more involved in our research of CP. I tend to be wary of. It's hard when we look at. I'm a mum, so I would hate to read too much into any involvement that my body has had in CP. I've worked with a lot of parents who put a lot of blame on themselves, the infection that they caught or the injury that they had during pregnancy. And it's so hard I can't even imagine what it's like for mums and families of going through helping, their children with CP. So when you're working with people with CP, please be sensitive around these topics, and please be mindful that there's a lot of grief when we deal with families, and so we want to be as compassionate and as empathetic as we can. You'll see a few slides with this researcher's name, Schultz, and obviously his research article in 2006, because I find it explains the muscle impairments for people with CP the easiest. So he looks at symptoms of CP in regards to deficit and excess symptoms. So deficit symptoms he describes as the signs of reduction or loss of normal voluntary muscle activation. So the loss could be a paresis, where there's inadequate force coming through the muscles. The muscles aren't being able to perform the movement they should be. He looks at the loss of selective motor control, so an impaired ability to activate and control movements across specific joints. So, for example, selectively, the motor control may be, I want to pick up that cup, and there may be an impaired ability of the shoulder, elbow, wrist, hand to be able to coordinate picking up that cup. Then we look at the loss of dexterity of movement, so the impaired ability to coordinate the temporal and spatial activation of muscles. So as we go to pick up the cup, we're looking at, can we coordinate being able to put our hand around the cup and lift up the cup without spilling the water. It also looks at the ability to adapt our movements to, for example, the cup is a mug, there would be different movements to if the cup was a plastic cup. And that impaired ability to coordinate those activations can create issues with our motor development. Then the last one under deficit symptoms is an enhanced fatigability. So we go to pick up the cup and we finally coordinate it, but we just don't have the endurance to do that. Either we don't have the endurance to do it over a long period of the day, or we don't have the endurance to pick up that cup and hold that cup all the way up to our mouth. So they're the deficit symptoms that Schultz describes, I believe, very well. He then looks at the excess symptoms. So these are signs of an abnormal involuntary muscle activation. So we're looking at passive movement, where we're not trying to move, we're not trying to pick up an object or do anything. It's just the muscles are having an experience of hypertonia. So as I was talking about in the spastic CP, where there's a resistance to passive movement. We're trying to open up the elbow or the hand here in this picture, and the muscles are resisting our ability to stretch and straighten them out. And this is caused by a continuous activation of the tonic stretch reflex, as I was talking about a few slides ago. So where we're looking at deficit symptoms, we're trying to move, but the muscles aren't doing their job properly. Now we're looking at, we're not moving, there's no requirement of movement, but the muscles are too tight and again, not relaxed how they should be. So spasticity is the resistance to the passive movement. And clonus is an interesting one. You may see this in there, particularly in the lower extremities. You may see this. If you go to give them a typical calf stretch, you'll go to push the toes towards the shin, as a typical calf stretch would be, and the muscle just seems, it's an unusual, once you've seen it once you'll always remember it, but the muscle as you go to stretch will resist you, but in a rhythmic pattern. It's sort of jolts back at you like we're pumping the accelerator of a car. It's an interesting muscle reaction, and it's called clonus, and it can be quite uncomfortable and frustrating for clients with CP. So just be mindful when you are stretching the lower limbs of a patient. be looking out for that clonus, and that can show that, again, the nervous system isn't functioning how it should be. We then look at active movement. So Schultz is explaining that we have mirror movement. So there's an involuntary movement of a muscle caused by a voluntary movement of the same. So for example, we may go to want to move the bicep muscle, but then there's an involuntary contraction of the tricep muscle. And again, the two muscles aren't working in unison together. We also look at, as we were saying before, there's an overshooting or undershooting of a target. So difficulty with spatial awareness, we're going to pick up that cup, but we can't coordinate how far away that cup is. So we either stop our movement just before the cup, that's called undershooting, or we push our movement past the cup, and that's called overshooting. So our movements look quite uncoordinated and jerky because we can't get the targeting correct. I'll show you in an image down the track. You'll see that in more detail. The abnormal muscle activity is creates not just issues with sitting, standing. It's to do with everything. You know, posture, the ability to move from one position to another. If the muscles aren't working in unison and they're not acting like a team, then our movements can't be nice and smooth and flowing. They're quite rigid and we call it jerky. So these are things to be mindful of. There's also another thing called co-contraction. So that means there's, again, the antagonist and the agonist. So the two muscles that are required when we go to bend our elbow, we need, the bicep to be the agonist, we need the tricep to be the antagonist, and they're not working together. One needs to relax for the other one to contract, and in this moment they're both contracting, and that's where that spasticity comes from. We just can't get the joints to move freely and how they should. As I was mentioning earlier, we sometimes still have infantile reflexes present where, we're supposed to get to 12 months of age. Those reflexes are supposed to be what we call absent. We don't see them anymore, but some people with CP, their reflexes are still present. So it's impacting our motor ability to move forward with the next motor skill. So you'll find that some people have hyperreflexia, so they'll be extremely reactive to a tendon tap. There'll also be nociceptive flexion reflexes, so they'll have an abnormal Babinski reflex where you run your thumb up the bottom of their foot. We expect a nice flowing reaction in someone over 12 months. We really don't expect any reaction of that at all, but they'll have an unusual painful reflex to that. You may also have abnormal reflexes where you go to do a patellar tendon tap and we expect for the leg to fling out as you tap the patellar tendon, and we don't get that. We don't get that beautiful smooth movement of the leg coming forward and back where the agonist and antagonist are working together. We may get an unusual jerking, or we may really not receive a reaction at all. So these things we want to look at. With the persistent infantile reflexes, particularly the Moro reflex, we want to be not seeing that reflex anymore, and in some people we are still seeing that. So, and we've also got the hand preference. We want to see that disappear after 12 months, and people with some people with spastic hemiplegia still have this present after 12 months of age. So all these things we really want to look at in our assessment and see what's going on, and then we can adapt our program accordingly. It's time for another question to get you thinking and see how you've been going. So hypertonia is characterized by resistance to passive movement caused by continuous muscle contraction, resistance to passive movement experienced by the examiner as increased muscle tone, fixed shortening of muscle and tendon resulting in a reduced range of motion. Good luck. We're going to look at basic motor control, so then we can start to realise where the challenges for someone with CP may start to occur. So with motor control, we have efferent neurons and afferent neurons. Afferent neurons provide the information to the brain about a stimulus from the environment. So for example, we tap on the patellar tendon and then we get an afferent impulse sent to the brain to go, oh, something's just touched my knee. The brain receives this information, it processes it, and it plans a reaction back to the stimulus. The efferent impulses tell the body what to do. I tend to try and remember it by efferent means effort, and effort is the action. Afferent is telling us about the environment. Efferent is the effort to make a reaction to it. That's how I remember, if you ever need to remember that. It's the beautiful flow that's supposed to happen when we have a tap on our patellar tendon isn't always happening. So either the information that's coming to us is incorrect, or the information that's being sent back as a response to that is incorrect. And these incorrect impulses stimulate that abnormal muscle contractions that we see in what we've mentioned above. So if we're thinking of typical, what we call neurotypical motor control, what should occur with the afferent and the efferent neural activity during a typical patellar tendon tap? And for those of you who may not know the answer to that question, what we should be seeing is the afferent neural impulses should send information to our brain going, oh, something's just tapped my tendon on my knee, and the efferent effort type impulses should be going, oh, that's going to send my reflex to kick my leg out smoothly. It kicks the leg out into a straight position and lets it go back to a relaxed dangling position, like the picture above. So that's what we should typically see for people who don't have cerebral palsy. And then to this slide, what may occur for a person with CP, we may see a dulled response to the patellar tendon tap. So the afferent, the information going to the brain, may not pick up that the patellar tendon has been tapped at all. Or it may receive the information, but then the efferent impulses may give an unusual jerky response, or an overreactive or underreactive response back in retaliation of the tendon tap. So it's quite complex in the process of it, but something that it can affect every movement for individuals with CP. So understanding how motor development works can sometimes help you to understand the challenges that people may be facing. I work with a lot of people from all walks of life. So I work with nurses, teachers, parents, and when we originally think about motor development, we think about the basics. So running, jumping, crawling, maybe handwriting if we're in a school environment, maybe getting on and off a bus if we're in a community environment. I really like people to understand that CP affects more than just that. It affects our ability to speak, to eat, to get dressed, to find money in our wallet, to pay for things in our environment. It's not just climbing, walking, crawling, jumping. So we're looking at our ability to move and interact in every environment that we're in, and we want to give them the best quality of life that we can. So when we're designing exercise programs, it's not just about getting them to walk, jump, run better. It's getting the fine motor skills as well. So when you learn about the strategies that I have in this course, it's going to be a lot more holistic and well-rounded than just those basic motor skills. If we go back to what I was talking about earlier with being able to target and pick up a cup, something so simple that we need every day, that's around this spatial relations or visual spatial processing. It's the ability to locate an object in our environment and also understand where that object is in relation to oneself, in relation to my own body. So this test that you'll see in this picture is asking someone just to tap from their nose to another person, and it's a simple test that we do for anyone who has a neuromuscular condition. And I just stand away from them and I say, can you please tap from your nose to my finger? And you'll see on the left hand side, that's what we get, a neurotypical response. So they'll be able to tap from their nose to my finger quite easily. Someone with CP or other neuromuscular conditions such as ataxia, MS, Parkinson's, you may see these where he'll tap his nose. So this is the picture on the right hand side. He'll tap his nose, but as he tries to get to my finger, there'll be an unusual motor pattern. We may undershoot, overshoot, undershoot, overshoot. We may not be able to even find our nose. There'll be all these visual spatial challenges that they may have. And this doesn't just impact the ability to touch my finger. It's our ability to find where our buttons are, to brush our teeth, to pick up a cup. So when we're looking at CP, I'm not just looking at strength and endurance and those basic functions. I'm looking a lot at visual spatial, because these are the skills that we need in our everyday life. And here we go back to the pictures of picking up a cup or pouring from one cup into another. If we have exaggerated stretch reflexes, or if we have poor spatial relations with our muscles, it's going to make this skill so very difficult. You can see in the top picture, we've got the bicep and the elbow at this point. It's the job of the bicep to, as the cup is filling, so picture number 2 on the right hand side, as the cup is filling, it's the bicep's job to tell the brain, oh, this is getting heavier, I need to adjust my force. And typically, if the muscles are cooperating and doing as they should be, then the elbow in the third picture down, the elbow will come back up and the bicep would have adjusted to that new weight. But again, if we're having difficulty with this, we may drop the cup altogether, we may bring the cup way too close and bend our elbow too much to adjust. And again, it's a simple thing we think of filling up a cup. So I always want everyone to understand that movement is so complicated, and we take it for granted, these simple skills of I'm just going to pour water into my cup and be able to hold my cup. The brain is an amazing thing when it's working how we want it to work. Unfortunately, in situations like CP, sometimes it just doesn't want to do what we want it to do. So one simple rehab skill could be teaching the bicep to deal with an added load. And, we don't want to get caught up in, well, I need them to run faster, walk faster, stand longer. It could be, let's look at these tiny skills that we take for granted, but helping an individual with CP to enhance this type of skill is going to mean so much to their quality of life. The reason why I'm passionate about my job in exercise physiology is for studies like this. I know it's back in 1999, but the studies are continuing to show that people with CP are at risk of being inactive or immobile. This is then leading to things like osteoporosis, diabetes, cardiovascular disease. And it's typically because when we have so much difficulty with movement, well, it's easier, it's less stressful, it's less frustrating not to move. When we have significant spasticity, it's going to impact our ability to move. So it's really important to try and get people with CP to move as much as possible. And this is going again we're looking at this continuum of mild to moderate to severe, and trying to get the best possible outcome for our clients with CP. For the fact of, things like osteoporosis, it's a concerning condition to get, and if we can get them with as much weight-bearing potential as we can, then we know we've done a really good job. We know we've done our best. So I tend to try and do as much standing activity as I can. For people with severe CP, I would use hoists to help. I would use standing machines to help. That's obviously a completely different session to what we're talking about now. For moderate, I would use as much, again, standing, walking as we possibly can, and then trying to get those bones to hold our body weight and to strengthen. Things to also think about is it's not just a motor disorder. I really want people to know that CP is not just a motor disorder. It impacts sensation, it impacts the ability for the brain to think, so it could be short-term memory, problem solving. We're looking at communication, the ability to express our needs, to understand what other people are saying. It looks at spatial awareness, which we've already looked at. We're looking at behavior when we're so frustrated and so anxious and the body's so stressed. It's not just the ability or inability to move effectively. A lot of my clients that I have too also experience seizures, epilepsy. So whenever we're working with someone with CP, it's a lot more complex than we would ever imagine, even to the point of complications such as feeding difficulties, drooling because, the muscles of the mouth are having trouble keeping the saliva under control. Osteopenia we've already spoken about, so not getting enough weight bearing through our joints. We may have growth problems because the spasticity of the muscles is impacting our ability for our bones to grow and develop. Impaired vision as well, so the eye muscles needed to track, to follow objects from left to right. Again, it's a muscle, so it's all going to be impacted. Not always, but a lot of the times, a lot of people with cerebral palsy have these challenges on top of being able to do, basic movement throughout the day. Hearing impairments and difficulty with digestion. So we're trying to understand the vast challenges that people with CP have, and if we can make a difference in any of those areas, we're really improving their quality of life. Let's now look at why exercise physiology is so important for people with CP. With the skills that we have, we can design specific functional and achievable exercise programs for people with CP. We have the potential to improve an individual with CP's ability to complete physically demanding tasks. We can reduce the progression of physical symptoms of CP, and we can help them to maintain a higher level of physical independence and quality of life. Pretty amazing what we can do. Again, we work on the continuum of mild to moderate to severe, and we can help. So for someone with mild, I love to help them with being able to crawl and navigate stairs and improve their ball skills. Someone with moderate, I like to improve their spasticity. I like to improve their ability to perform those activities of daily living where we can pick up a cup, brush our teeth. In the severe, I like to help them with pressure sore management, so around being able to get them comfortable in their position, even just being able to improve their eye muscles so they follow things better. All these things are adapted to their needs, and I love the fact that exercise physiology can do so much for people with CP. I'll start with explaining the early intervention that I do. So as I mentioned before, typically I work with adults, but I also do work with kids in a school setting. So early intervention typically involves facilitating the development of those milestones. So being able to crawl, being able to grab and release an object, static standing, being able to sit not just on a chair, but being able to sit on the mat, on a stool. And then we're educating a lot of parents about CP. What is it? How can we help them? What services are available? And then I do a lot around muscle tone relaxation and activation. So how to teach the muscles to calm down, how to teach them to increase their tone, and core stability is a lot of what we do. So to be able to do those things of crawling, balance, sitting, we must have the core muscles doing what we need them to do. Core muscles are basically our really strong belt that keeps the body upright. So a lot of the things we do, even in crawling, I had, a little boy who was 6 learning how to crawl again. I've had kids who in their teens crawling because we've missed those steps, or we're having challenges with our core. So these strategies can be used across the lifespan, and it's just getting people involved, parents, support workers, teachers, so they know the importance of movement for people with CP. The first thing that we do in the role of an EP or exercise physiologist is an assessment. And my assessment starts with a postural assessment. And I can start to see this as I approach my new patient, or we go for a walk together and have a chat about what our goals are. And I start to look at these types of gaits. So we have the spastic gait, which we were talking about before. We have a scissor gait where the feet tend to cross over each other, then they knock their knees. We have a propulsive gait, so the center of gravity is over the front of the front foot. Then we have the steppage gait where you can see the knees, behind the back of the knees are unable to control that forward propulsion, and the feet as well. And then we have a waddling gait where the core and the pelvis aren't working together how they should be. So I look at gait first. I can then see just in the way that they are standing or the way that they move, whether it's, so again, hemiplegia, one side, diplegia, more legs than arms, or quadriplegia, all quadrants of the body. And then doing that initial assessment and observation, I can see the challenges that they're having. But the next most important step, which I'll show you now, is setting up those goals for someone with CP. So I want to make sure that the goals are specific to the individual, and I don't want to just achieve normalcy. I don't even like using that word. One client that sticks with me forever, I had him 10 years ago. He was a 17-year-old boy with CP, and his mum was doing the right thing. She was trying what was best for her son, and she wanted him to be normal. Again, I don't like using that word. And he didn't. He didn't want a bar of my exercise program. He said, I can get from A to B. I can go and hang out with my friends at the shops. And his specific words were, don't try to fix me. So goal setting's huge for me. I'm very strict on sitting down with every individual and going, what are your goals? What do you want to get out of this? I don't want to push a goal on you because that's what I believe exercise physiology should provide. I want you to feel comfortable and I want to achieve your goals. They're not my goals. So, look, my ultimate goal is to help people become active as possible. Ideally, I'd love their optimal level of independence and quality of life. I'm all about getting them to be comfortable in their local community. But again, if it's not my client's interest, if it's not their wishes, then I don't push the issue. So really, really can't stress that enough. From a physical therapy perspective, I look at the muscles. I'd like them to get to their optimal length. I'd like the spasticity to reduce. I look at pain management. I'd love the bones to be getting that body weight and that compression that they need. So we're reducing osteoporosis. I also want them to get a little bit fitter so our heart and lungs are functioning better. But again, it's the goals of the individual with CP. They're not my goals. Long-term strategies, of course, I always consider in my initial plan. So I'm not just the only health professional in the team. I look at whether they need more education, whether they need advocacy at their school or their work, whether they need referral to other health professionals. Say, for example, they're having trouble with speaking or eating, I would go straight to a speechy for their professional advice. If they need handrails in the home, I'd go straight to an OT. If they need counselling or support for an advocate, I'd look at social worker. So again, exercise physiology, we're just a small component of CP, and we're trying to do the best we can to achieve the outcomes that the individual has come to us for. Again, when we're designing an exercise program, each exercise that is prescribed needs to be specific to the strengths, weaknesses, goals, interests, and potential of the individual. So research in this area is very limited. I've been trying to search for research articles to cover CP-specific intervention, but we really, if we can improve their physical fitness of people with CP, that would be fantastic. I look at neuromuscular rehab to design my programs. So tapping into those areas is important. Again, going back to what we were talking about before, improving visual spatial ability. But I'll go through a few ideas here, but please know that research in this area is quite limited. I've gone through the research as much as I can. A lot of my strategies are neuromuscular based across the board, so I may use these strategies for someone with multiple sclerosis, Parkinson's, ataxia, again, any condition that is struggling with the coordination of movement, and keeping in mind that we're looking at the individual goals, strengths and weaknesses. In 2007, when you look at Verschuren's study, they suggested that each session lasted 45 minutes. We have a 5-minute warm-up period, 25 to 35 minutes of functional aerobic, anaerobic and muscle strengthening exercises, and a 5-minute cool-down period. Typically what we would expect. An aerobic exercise duration was 3 to 6 minutes and anaerobic was 20 to 30 seconds for each exercise. And this was may not suit every individual, but this was what the strategy that they had. They tried also to do several short sessions of 5 to 10 minutes per day for individuals who can't commit to the 45-minute session. Typically, that would be what we would say for the healthy population, but I would still be mindful of people with CP. I want to always take into mind whether they have epilepsy. I want to look at their body temperature. So if they have epilepsy, I'd be monitoring their body temperature, because a spike in body temperature can trigger a seizure. I'd be looking at the environment that they're exercising in. So are they indoors or outdoors? I would look at their endurance that they came with. Some of my clients would only get through 15 minutes of a rehab program before fatigue would hit. So these are very general outlines, and I like to use research studies, but what I found in working in this industry for 10 years is that there's not a one size fits all category. As long as we're being mindful of the risks for the patient, we're being mindful that we're looking at all of their stats. So blood pressure, heart rate, oxygen levels, keep them all checked throughout the whole session. We want to make sure that the body is safe and that there's no risk to the patient. Now, this may be obvious for some of you, but I like to mention it because sometimes we don't think of the obvious. When we're working with someone who has CP, especially those that have the athetoid or dystonia CP, please avoid free weights as much as possible. If you can imagine, an involuntary body movement could flick the free weight out of their hand, and then you've got an injury. So I avoid free weights wherever possible. If you have access to the hydraulic weights machines, that would be ideal. But again, I just don't advise it for people who can't control their voluntary movements. So it's not worth it. There's so many other ways that we can improve the strength of our body through our own body weight exercises. If your patient has athetoid or dystonia CP, there's just no point doing free weights. Again, unless they're an experienced exercise participant, if you can spot them, if it's hydraulic weights, but typically please be careful before you put weights into the hand of someone who has involuntary body movement. Another really important thing, when we look at CP and we look at the difficulties that the brain has had with oxygen to the brain, please ensure that the clients don't hold their breath during exercise. It's so important to maintain that oxygen flow to the brain. And I really want to make sure that everything is safe for anyone that we provide a program for, but particularly for people who have a neuromuscular condition. If we think about, our heart is a muscle, our chest muscles are controlling our breathing, and if they're not functioning properly, we've got a risk to our patients. So please make sure they do not hold their breath during the resistance or the effort phase of any exercise. And of course, typically what we would do for anyone, we need to make sure if there's any muscle, joint pain or swelling more than 48 hours after an exercise program, seek medical assistance straight away. It is quite serious helping someone with CP through an exercise program, so being mindful of all these things is really important. Over time, we still stick to the general program considerations that we always have. We want to increase the duration, intensity and frequency over time as they become stronger and fitter, but we definitely want to look at lightheadedness, chest pain, difficulty breathing, excessive fatigue, nausea, again, that joint or muscle pain. Stop exercising immediately and go straight to the GP before starting again. So be mindful of all of those things. Also, typically, we need to drink plenty of water. We need to wear appropriate clothing so we don't overheat, as I mentioned before. Appropriate footwear that's safe. We want to adjust it if we're in extreme heat or cold, because people with CP can have trouble with regulating their body temperature. And if your client has an epilepsy management plan, make sure you read it. Make sure it's on you at all times. Make sure the patient is aware of what to do, and take that very seriously. You may find also a lot of people with CP are on a range of different medications, and this can alter how their body responds to exercise. So make sure you discuss this with them. You know exactly what medications they're on, and you have all of this planned out beforehand. I've categorized the exercise program types into these categories. So we have to reduce progression of physical symptoms, to improve ADLs or activities of daily living, to improve motor control, to improve communication, to increase physical activity levels, to improve sensory integration or the sensory awareness that I was speaking about before, and to improve balance. So we'll start with exercises to reduce progression of physical symptoms. These following exercises are predominantly provided for those with the severe form of CP. So they're unable to control their voluntary movements and they may have difficulties with most activities of daily living. So I do passive stretching of the hands to protect skin integrity, passive stretching of the wrists and elbows to reduce further contractures and discomfort, gentle mobilization of shoulder joints to reduce pain. Please keep in mind that the shoulder joints for someone with CP can easily be dislocated, so be very careful when you're moving someone with CP or when you're working with their upper body. I look at ways to reposition their seated and laying posture to prevent pressure sores. So it may be putting a cushion in for comfort. It may be teaching family the manual handling and the biomechanics of how to safely reposition them. I also look at passive stretching of their hip adductors. Their adductors will be tighter than their abductors because of the way that the CP is impacting on contractures. I also look at stretching their hamstrings and their calves as they do get very tight in CP. And then we look at, as I said before, it's education about safe patient handling to make sure we don't dislocate any joints and to keep them comfortable. The next one is exercises to improve strength. So researchers do believe that strengthening spastic muscles, they used to believe that it would only make them stiffer and only make the spasticity worse, but researchers also found that strength training can benefit. So again, we need more research in this area, but if you make sure that you're not putting too much load on the muscles and you're just doing a nice low weight, then there's evidence for both. What I look at when I look at strength training is I want it to have a functional goal. So I'm not just giving them a typical exercise program that I'd give everyone else. I'd ask them what their challenges are. So if their challenges are getting in and out of a car, then I would look at the muscles involved in getting in and out of a car. For example, I'd want to strengthen the triceps because the triceps is what gives them the upper body push that they need to get out of a car seat. And I'd strengthen their quads because the quads is what's allowing them to get into that squat position in and out of their car. You'd develop that on top of that, but they're just basic things that I would do straight off the bat for someone whose goal is to get in and out of a car. It's not just about, again, cycling, swimming and walking that we're looking at. It's what are their goals? What are we trying to improve their strength in? Their strength could be just as simple as the strength of their mouth muscles to be able to suck out of a straw. The strength may be I just want to be able to step up onto a curb, just a small step. Then we'd be looking at plantar flexion, ability of their quads and calves to work together. Those sort of chain exercises could help. I wouldn't put massive weights on on a strength program for spasticity reasons, but it doesn't mean that you can't use really light resistance to get the body to learn how to coordinate better. We look at a wide range of different activities. So for neck strength, I make noises around them, so they have to look towards where the noises are and improve the strength of their neck. I look at throwing and catching and making the head lift up to throw and catch. For core and postural control, I recommend horse riding. We get them on a scooter board, the like a little trolley that has 4 wheels. I use fit balls, Duradiscs to try and build up their core. I love encouraging swimming. Swimming is fantastic for pain relief, for spasticity, and for core. I look at rowing. Some of my clients love to go sailing for their postural control. Lower extremity, I look at leg cycling on either a stable bike that they can get on and off of. Be very careful of getting on and off a bike when you've got CP. Stair climbing, I look at sit to stand activities with or without a support. You can do amazing TheraBand exercises while they're sitting in their chair. I also look at the upper extremity. So again, we do rowing either in a gym Again, I don't put resistance on it. I just get the technique right first and the flow of the movement first. Arm cycling is just putting the arm ergometer on the top of a table with or without support from someone. You may need hand support if the hands do let go. So again, always think of the risks before you do any of this. Theraband activities are great for the upper body, and very light free weights if they can keep hold of the weights. On this slide, you can see exercises to improve ADLs, or activities of daily living. I focus on the muscles that are causing the most challenges with their mobility. So it's having those conversations with them at the start about going throughout their whole day. What challenges do you have? What do you find easy to do? What do you find exhausting to do? And the postural assessment is crucial to tell us what muscles are weak, what muscles are tight, and we'll always strengthen the muscles that are weak and we'll gently stretch the muscles that are tight to get that unison between muscle groups. I like to practice the ADLs in amongst therapy, so I make it fun by, following them throughout their house, helping them walk to the letterbox. If the goal is to climb stairs, we look at climbing stairs safely. I look a lot around the upper extremity of being able to manipulate and hold knives and forks, pick up a cup, a varied weighted cup, different types of cups. I do a lot of tearing activities. Tearing is really good for pincer grip and for hand strength. I do a lot of scribbling and drawing and cutting with scissors if they can. Again, safety, safety, safety. We might go together to collect the mail. I've done sessions where we bake together to look at how we get hand control in baking. Options really aren't just stuck in the gym setting. I like to have it that it's functional. So gym programs are fantastic and they're so good to get people out and about and in the community, but I'm really conscious that it needs to be functional. These exercises need to help their everyday life, not just the times that they're in the gym. Exercises to improve motor control is where I'm most passionate about. I find this more play therapy, really. So I do fine motor skills where I use pegboards, wooden jigsaw puzzles, Play-Doh, Lego. I use doll houses for kids, train sets for boys. I'm looking at, in this category, grasp and release. So ability to pick up an object and calmly and slowly release it without dropping it. So the pegboards is I want to pick up a piece on my right hand side, I cross the midline and put it onto my left hand side, and it's all trying to get that beautiful smooth motor control without it being jerky or involuntary. I also do things like where we push a small ball across the table to each other, so we're targeting and trying to get to each other. Throwing a small ball is also we grasp the ball and then we have to release the ball with coordination. With targeting also, we place shapes into a box. We make it fun by picking up different objects. What is it? We guess it. Throughout these activities, when we get frustrated, I integrate mindfulness and relaxation because I want the muscles to relax, and I know that when we relax, the muscles will relax even more. So again, motor control is fun. It's supposed to be interesting, and I don't like rehab to be boring and monotonous. So I just create a program out of being creative. I'm creative and I like to promote all these elements of spatial awareness, but in a fun environment. It just makes it more interesting. These people who have had CP have been in and out of therapy rooms, most of their life. So if we can create one that's enjoyable and fun and exciting and not just your mundane, boring exercises over and over again, then I feel like I've done my job properly, and I feel like I've made their day a little bit more interesting than just boring rehab. I also do a little bit around communication. My role has been in adults who particularly don't speak, so about 80% of my clients are non-verbal. So I like to do communication. I always refer to a speechy wherever possible, and throughout my role over the 10 years, I've learnt different strategies like this to help people to improve communication. Such as I love to involve rhythm into any movement. When we involve rhythm into movement, the muscles, actually the brain is stimulated in the musical area of the brain. So I like to sing songs and clap to music. I like to play to music. I like to move to particular rhythms and patterns. It's all getting the body to work together. And if we use music and calm the body down, if we use music to tap into motor memory, then again, it's language development. It enhances communication. It enhances quality of life, and that's what I'm in this for. So I can also do things around imitating the mouth muscles. So I open my mouth really wide, I close it tight, I be silly, and I stick my tongue out. I make different speech sounds for kids, so I might go choo 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 or ba ba ba, and we practice those sounds and we exaggerate the movements of our mouth to do that. I blow bubbles with varied straws, so we start with a really thick straw where we get a lot of air pressure, and then we try to go down to a smaller straw, and we blow ping pongs across the table to make it fun. So again, I consult with a speechy all the time about their skills and what they recommend, and then I try and just build it into the therapy program. So while they're there and while we're already in therapy mode, we might as well try and incorporate as many elements as we possibly can. A passion for me, of course, is also to increase physical activity. So as I was saying before, people with CP predominantly have a lower physical activity involvement. So I try and get them to come, into community activity as much as possible. In school, I have modified PMP programs where we adapt the PE program to suit people with special needs. I love seeing sports. Tennis is my passion, so getting sports tennis coaches to adapt their lessons to help people with CP. It's just taking it across the community to get it more accessible for people with cerebral palsy. We want to make the equipment more accessible. We want to make the environment more accessible, and then we can get so much, involvement. And it's not just about physical activity; it's about community connection. So increasing physical activity is getting them involved in sport as much as we can, involving all those exercises that we've already gone through: cycling, TheraBand, walking the dog, throwing and catching with mum and dad, doing an obstacle course. It all adds up, and the more we can move, the more our motor control will improve. So there are just a few ideas for you. An area that we can't forget is balance. We must work on improving balance. That could be sitting balance, standing balance, dynamic balance, static balance. There's so much involved in balance. I really should create a session on balance for those that are interested, because balance gives us our ability to stand and use our arms and legs freely. It gives our ability to sit on different types of seating. So one student that I had yesterday, he's 6. I was getting him to crawl. He'd never been on a stool before. So he'd sat on a chair. He struggles sitting on the floor, and he couldn't sit in art class because he couldn't sit on a stool. So that now is part of my therapy program, to get him to be able to participate in art. So we want to look at balance, and how we can promote it, how we can improve confidence in it. So we can involve ourselves in all these activities that a lot of us take for granted. So balance activities obviously vary depending on the mobility of the person with CP. It could be just static standing balance where we close our eyes, open our eyes. It could be standing on a Duradisc, standing on the floor. Dynamic standing balance, I work with reaching forward, reaching up, reaching down. I might tap a balloon from side to side while standing. I do gentle seated perturbation. So what that basically means is we sit and I just shift the body slowly with my hands from left to right, and the body has to catch itself before it falls over. So that can help with motor control. I look at, as I said, throwing and catching, tapping a balloon. Obstacle courses are fantastic to get the body to test its balance. Balance is always done in a very safe environment, but we need balance. We need balance for every part of our daily life. So please never forget to include balance in your programs. Pain management is also something that I'm really passionate about, because I want my clients to be able to experience a good quality of life. So I'm constantly asking them to complete pain scales from 1 to 10. How are you feeling? I look at their body language before, during, and after each session to see, how they're going, how their pain is going. And then I usually would encourage pain management with a care team because, research has shown 86.4% of people with severe CP experience pain, but they're not on regular medication. When I ask support workers, so what are they on today? What meds have they had? Oh, we've had 2 Panadol. And when you look at how much pain, their muscles must be in, 2 Panadol, we want to get that sorted out with qualified pain management specialists. So a few chronic pain management specialists are around in our area, and I always like to just refer to them for a consult, just so we know that their quality of life is as best as we can have. And look, we always need to talk about the barriers to exercise. So we've gone through this already. We have, physical activity. There's a number of reasons why we have barriers. It could be financial. It could be transport. It could be, my client who said, I don't want to do exercise. Don't help me with my condition. Don't fix me. It could also be that accessing a gym, physically accessing a gym, getting on and off equipment. So we want to try and make it as accessible as possible for people, whether it's we provide these services at their work, at their school, at home, whether we provide equipment such as a TheraBand that could be taken anywhere to exercise with. We want to knock down as many of those barriers as possible. We still need to respect them though. So if they genuinely don't want to participate, we allow that. So trying to keep all of these things in mind before we start a program is fantastic. A few simple strategies that we can try for each barrier is, if it's physical barrier, we can modify activities, we can use support aids. If it's financial, then there's lots of different funding options we have. If it's behavioural, make therapy fun, make it creative, develop a behaviour management plan if it really is that severe. Some of my clients do have a mixture of conditions. They may have cerebral palsy and autism. So adapt it, make it that it's accessible through adapting it to suit their needs. Communication, again, consult with a speechian, see what PECs or visual charts they're using. And socially, bring them as a group, involve family, do it in the home, whatever's going to make it comfortable and be able to help them to get the rehab that they need. I put this slide in all of my presentations because I really need you to know that this information is only guidelines. I haven't met your client. Each client with CP is completely different. So please consider and assess them individually. Consult with their medical team so you know exactly what you're working with. And before commencing any exercise program, think about the risks, think about the goals, and keep your client's interests in mind. If you have any questions, please feel free to check out my website, email me, and ask any questions that you may have. I also have a Facebook page, Move Number 4 Health. Come and visit us there, and other families may be able to support you. And I'd just like to finish off with thanking you for listening to my training package. Again, it's nice to know that there's so much out there to help people with CP. And if there's ever any advice you have or strategies that you found have worked, please do share them with us and we'll get them to those families in need. Thank you.